Thank you very much. I'm humbled. Is there any way at all anybody knows how to turn the lights down? I'm a radiologist. I like it dark. Thank you very much. I have to say, after seeing Dr. Sugarbaker's video, that I am humbled because I think that the ultimate imaging device is going to be is really bright lights and cold steel when it comes to finding this disease. But my intent here is to simply show you perhaps what some of the contributions are to that radiology can make in cross-sectional imaging, in particular with CT and MRI, may be able to provide in the care of these patients. I have not drunk any Kool-Aid. I'm not here to sell you on anything, but I do want to at least try to show a few cases that will illustrate what we do. And of course, when we do something, we have to have a thesis and a rationale for imaging. And my goal as a radiologist, when Dr. Salty sends, or his team sends a patient down to radiology, usually it's in the preoperative setting, and we want to find disease. We're looking for preoperative identification of disease foci in an attempt to determine who's eligible for cytoreductive surgery. So it's really incumbent upon us to try to do the best job we can and to use the best protocols that we have available, and I will be talking a little bit about protocols for you. Postoperatively, we think that imaging enables detection of low-volume disease, and as a radiologist, it's really about the low-volume disease. Dr. Sugarbaker and I were talking before about 7:30 this morning, and he made the comment that imaging is tough. Not that my job is tough, but I think it's hard to be able to produce sometimes credible results because we know that the oncologist is looking at the patient's overall well-being, they're looking at tumor markers, and we're looking at the results of imaging, and we'd like to see the three match, and they don't always. So we do our best in order to try to identify a low-volume disease, which we're classifying as less than 5 millimeter disease, because it's very important prognostically. In the secondary cytoreductive setting, imaging is attempting to distinguish localized from multifocal disease. The more disease that I can find, presumably that has an effect on the nature of the conversation that the oncologist or the attending surgeon is going to have with that patient, and presumably is going to have an effect as to what they do in those patients. Like I said, I did not drink the Kool-Aid. There are shortcomings to any imaging modality. Dr. Claire Tempany from Brigham and Women's published a report in the journal Radiology in 2000. And in that article, she basically illustrated not so much the instrumental limitations as much as the human limitations, because interpreting images is very much a human activity, and our performance is not perfect. And in that study, she found that, if you look at per patient using either CT or MRI, that our sensitivity was pretty good, but if you strip out the data and you look based on a per lesion sensitivity, based on location, for example, and we talked about the subdiaphragmatic spaces in the bare area of the liver and all of these difficult things that you probably don't think about routinely, either as a patient or as a primary care physician, then the numbers don't look so great. So my goal as a radiologist is to view as much of the peritoneum as I can, including the peritoneal ligaments and the peritoneal surfaces. And these are some of the things that we think about, and it was thrilling for me to be able to see the video because I'm always looking at representations of those anatomies, and it was fun to actually be able to peer into somebody's abdomen and see it in vivo. And I think that's a very definite advantage that surgeons have, and probably explains why surgeons were the original radiologists way back in the day. But we look for the various intra-abdominal ligaments, including the gastrocolic ligament, the gastrosplenic ligament, the pharynacocolic, and the gastrohepatic ligament. We do not always directly visualize those structures in normal patients, but as you'll see later, we can, in some cases, infer their location when there's extensive disease based on the distribution of the disease in the abdomen. The bowel serosa is another area that we look at. That is our most challenging task, but we search the pericolic gutters, and then Of course, the peritoneal reflections and pelvic sidewalls, and you saw that elegant dissection of the uterus and the cul-de-sac ectomy that was performed on the video, as well as the omental surfaces, including the greater omentum or the so-called omental bursa. And I apologize in advance. Sometimes there are differences in anatomic terminology that a radiologist will use compared to a surgeon, but we're both talking about the same thing. It's also very important, as Dr. Sugarbaker alluded to, both in his discussion and in the video, to be able to get a look at the various intra-abdominal spaces, including the hepatorenal space, which is Morrison's pouch. The most common finding that we will see there is simply fluid, but I will show you some examples of other pathology that can happen in a patient who is CT negative. We look, the right subphrenic space is a toughie because of the bare area of the liver. I think imaging has a really hard time with that, regardless of whether or not it's CT or MRI. The pararenal spaces, I think, are readily accessible to imaging, and the lesser sac is something that we routinely inspect, and that being deep to the gastroduodenal ligament. This is a diaphragmatic representation of what was referred to before as sort of the pathways that these cells take when they slough. We are upright human beings. The diaphragm works as kind of a pneumatic pump, and there are flow directions that will normally happen when tumor cells are sloughed into the abdomen as an exudate from intraperitoneal tumor. If you remove the liver, the colon, the stomach, and just look at the footprint of those organs, then we can see diagrammatically these various spaces, including the right subphrenic space, left subphrenic space, the pericolic gutters, and the peritoneal recesses within the pelvis. The root of the mesentery divides the small bowel mesentery into what we refer to as a right infracolic and a left infracolic space. And it helps us to try to compartmentalize and describe to the surgeon exactly where the disease is. I don't know if this is an incident report. I got this out of the literature. Would a person put contrast material into a peritoneal dialysis catheter? Some nurse could tell me. Well, that's what happened here. This is a coronal CT scan, and I only show it to you because it actually demonstrates that these structures really do exist. This is the liver, the spleen. This would be the left subphrenic space. Of course, it's greatly exaggerated because the fluid has filled them up. The right subphrenic space, bare area of the liver here, Morrison's pouch, the phrenicocholic ligament, and the gastrosplenic ligament. And like I said, in the normal person, you may not see those structures directly, but when disease happens, that's when we really kick into high gear in an attempt to describe to the surgeon where the disease is. Here you can see exactly an example of that in two different patients, one with ovarian carcinoma and one with pancreatic carcinoma. This is your image on your left is a coronal CT, and just for orientation, this is cephalad, this is caudad, this is right, this is left. This is the stomach. We have the greater curvature of the stomach here. These are the gastroepiploic vessels, and you can see that the colon, the transverse colon, is depressed, secondary to what some people refer to as cake. I think it's frosting more than anything else, but it's bulky tumor that we see growing between the stomach and the superior margin of the colon along the distribution of the gastrocolic ligament. So yes, the gastrocolic ligament really does exist. This is a different patient with pancreatic carcinoma. This is a sagittal reconstruction, and if you look anterior, posterior, here's the patient's spine, here's the crus of the diaphragm that Dr. Sugarbaker was so gently dissecting and describing. And if you look sagittally, the transverse colon is here. We all learn in medical school and in radiology residencies that the transverse mesocolon runs anterior to the pancreas and inserts along the mid-inferior portion of the colon. And here you can see all of this tumor studding, both in the lesser sac and extending along the transverse mesocolon. We also incidentally see the greater omental fat here, which is full of disease. And then these low-density areas here represent ascites. So you can give the surgeon a precise area of the disease distribution, which is really what we try to do. This point has already been made. Peritoneal carcinomatosis is a process of sloughing. The movement of the tumor cells. We're upright human beings. We walk on two legs, is aided again by the pneumatic pump of the diaphragm. and the flow of ascites in those predictable sort of pathways that we've discussed. And those can result, from my standpoint, in areas that some people have referred to as peritoneal hot spots. And I use the term advisedly, not to suggest that they are hot in the nuclear medicine sense, but they are areas where there's a lot of action and where you really have to run your eyes over and make sure that nothing is going on. And where are those areas? They are in the pericolic gutters. They are in the omental fat. We look along the small bowel mesenteric root and in the subdiaphragmatic and hepatorenal spaces. Again, the subdiaphragmatic spaces being really tough for us. I don't think we do the greatest job there. Focal disease manifestations, bulky disease is not a problem, and I'm going to show you examples of bulky disease. You don't need to be a radiologist to look for bulky disease. This is where the action is. Individual or multiple nodules, low volume disease is our greatest challenge, especially in a patient who has positive tumor markers, who is doing well, and who, for example, may have a CT scan that is normal, and we're really trying to figure out better what's going on in terms of identifying measurable disease. This is a patient with bulk disease that we can see on the sagittal CT. This is the so-called omental cake. This was metastatic colon cancer. There are bits of ascites in here. This is the tip of the right lobe of the liver. Here is some more of the omental fat that is infiltrated. You can see the peritoneum here in the left pericolic gutter. This is not a challenge. More often than not, we see what we refer to in our department as dirty fat. A patient will come in with perhaps nonspecific symptoms. They don't feel well, they feel bloated. We do a CT scan, and lo and behold, we kind of see some medium volume disease. Here we have tumor studding. This is pretty typical and very commonly seen in the omental fat. And these are not problematic diagnoses. This patient came in to our Edward emergency room one evening, unfortunately about 11:30 at night, but we had had enough coffee and were awake and a few Cokes, and we're all tanked up with caffeine. Patient came in with abdominal distension and symptoms of a small bowel obstruction, and I think we can all see that there is evidence of intestinal obstruction. This is the greater curve of the gastric body and the greater curvature of the stomach. There's fluid up here in the right upper quadrant, and that fluid, to my eye, is a little dense, which would suggest that it's not just simple fluid. Perhaps it's an exudate, perhaps it's fluid that's bloody. It's not garden variety fluid. But if you look very carefully, this is fat in the region of the left pericolic gutter, but this is omental fat in the upper quadrant. And if you compare this fat to this fat, this is what you see with peritoneal carcinomatosis, which was the cause of this patient's small bowel obstruction. So our challenge in imaging is really to improve the sensitivity to low volume disease. As far as I am concerned, that is where it's at. Because radiologists at this point in history have sort of this idea, maybe it's a delusion, that we would like our imaging exams to be at least an indirect biomarker to what's going on with the patient's tumor markers and to their overall clinical status. That is the constant challenge and the constant attempt to improve the state of the art. To that end, you've probably heard of diffusion-weighted imaging. I'm going to talk a little bit about magnetic resonance. Maybe you've seen this in your reports. I know that if you take care of patients in the setting of stroke or neurological disease, diffusion imaging has been present for many years and is used every single day. We've begun doing this over the past 2 to 3 years after Dr. Salty started his service here at Edward Hospital, and it has added something, I think, to the workup of some patients. The physical basis for molecular diffusion was initially described by Dr. Einstein in the Annals of Physics in 1905, but it wasn't until 1965 that two physical chemists, Dr. Stakal and Tanner, to whom the diffusion-weighted pulse sequences are named after, came along and actually figured out what the molecular behavior of free water molecules and mobile protons were in the presence of a magnetic field using a benchtop NMR spectrometer. And it's that same instrument that if you took organic chemistry in pre-med, and at the end of the 4 weeks, you ended up with a speck of dust that was in your lab, and that was your grade, depending on the purity of the spectrum. That was the way in which they were describing this phenomenon. So it is truly a form of molecular imaging. So what is diffusion-weighted magnetic resonance imaging? I think most of you have seen just an ordinary MRI examination, and I'm not going to get too much into the depths of this, but I will show you both examples. But to put it very simply, diffusion is the process of visualizing the displacement, molecular displacement of the thermally driven motion of water molecules. So we're imaging motion of water. It's a motion scan. And what's important is that the degree to which we see this diffusion, which is clinically significant, is driven by a few factors. You have to have an intact cell membrane. You have to have active transport mechanisms within those cell membranes that are working. And the key circulation, which Dr. Sugarbaker alluded to in his discussion of chemotherapy efficacies, you have to have an intact microcirculation. Whenever you have interruptions in any of those things, then you will have changes in diffusion which will occur from baseline and most commonly after the effects of chemotherapy. I want you to ignore this because I'm not sure it's correct, but the most important thing is that with intact tumor, because the cells are slightly packed, the tight junctions are intact, the cell membranes are intact, the mobility of intracellular water is very limited, and therefore the diffusion is limited. And we define diffusion occurring in terms of what we refer to as an apparent diffusion coefficient. With tissue necrosis, I think it's kind of intuitive. You have cell death, you have breakdown of microcirculation, you have breakdown of cell membranes, you have release of intracellular water, and that will change the diffusion characteristics of tissue. And these things can be clinically significant. How much movement, how much diffusion is really going on? I just show you this. The diffusion coefficients are derived from the application of multiple diffusion gradients. You don't necessarily have to know that. But the point is the instrumentation is so advanced nowadays, and I've been looking at magnetic resonance images for 30 years. And when I was a fellow at the University of Pennsylvania, none of this was even imagined. And now we are looking at the infinitesimal amount of molecular movement inside these cell systems on the order of 10 to the minus 6 millimeters squared per second of exposure to a magnetic field gradient. This slide simply illustrates the fact that there are different diffusion values for different kinds of tissue. And I think that if it's intuitive, if we just look at this, I think we can all understand that for free fluid in the abdomen, diffusion would be very, very high. Whereas for solid organs, such as take for example the liver, or take for example uterine myometrium, or a solid tumor, diffusion tends to be lower. We refer to that as restricted diffusion. So in doing our clinical patients, we produce two kinds of images. We produce an image which is referred to as a diffusion-weighted scan, and that is a T2-weighted scan, and what that basically means is that the bad stuff is bright. And we produce what is known as a calculated image from those sequences, which is an apparent diffusion coefficient scan. And I will show you why that is relevant. Code red. Are we on fire? This. Let us know if you need any help, Elmhurst. This is, again, this is our patient with the high volume disease. This is a CT scan, and my point, this is a diffusion, an apparent diffusion coefficient image showing the relative high signal of the acidic fluid, because fluid is sloshing around and free to diffuse, and the relatively low signal of the restricted cells within viable tumor. I'm going to show you some more examples. In the setting of HIPEC, we rely predominantly on the diffusion-weighted scans where the bad stuff is bright because it increases lesion conspicuity, and I think I think we've probably had in some of our patients our greatest success in looking in the postoperative setting for patients who may have residual small areas of disease when CT is not helpful. On a good day, this is an ordinary proton density or T1 weighted image, you may, if you're really awake and alert, you may understand that this is actually a real lesion in a patient with metastatic colon cancer who had undergone HIPEC. This is the diffusion weighted image where, again, to first order, kind of simple way of thinking. Bright is bad, with the exception of the normal spleen and kidney, and here we can see a very nice example of what turned out to be a small metastatic deposit. This is exactly what I'm talking about here in this case, and I think this probably illustrates the strength of being able to use diffusion-weighted imaging. This is a patient who was CT negative, who has had chronic, lingering, low-level positive tumor markers, but who has otherwise been doing clinically well. And we can see here CT was really not helpful, but this is the right lobe of the liver, down near the tip of the right lobe, and we can see these very small, tiny little tumor deposits, and they have persisted over time. And this, I think, is where we can potentially make a contribution. A quick word about protocols. Your patient has to be able to cooperate with the technologist. Why? Because we're imaging molecular motion. If the patient is crabby, if he's agitated, if he's hypoxemic, if he's hungry, if he's out of sorts, if he's moving around, we are not going to be able to get any useful data out of those patients. The other thing that I would like you to know is that we do infuse the patients with IV glucagon. They all get 1 milligram of glucagon in an attempt to paralyze gut peristalsis so that there's no possibility that peristalsis could induce a false positive result on the scan. Let me just say a very quick word. Somebody may be thinking, why don't we do PET scans? PET, I think, in our hands is very good for solid tumors and solid organs and looking at nodal metastases. But if the name of the game is to find low-volume disease, there may be resolution images, but the big bugaboo with PET, especially FDG, is the fact that the FDG is secreted by the salivary glands, the patient is swallowing activity, and the colon will also secrete this activity. So it's really not in the ball game. So let's just look at a few cases and then we'll wind up here. 69-year-old female with preoperative planning for interval debulking surgery after 3 cycles of neoadjuvant chemo in primary peritoneal carcinoma. This case is not from our Edward experience. I took this from the literature only because it illustrates a point. And the point is, you look at this image, this is a T2 weighted image, and we frequently are confronted with a situation where we're looking at something like this and there is no CT scan. It can be tough. This is the tough part that Dr. Sugar Baker was relating to. Fortunately, this diffusion-weighted scan, if you can see, this would even be better if it was totally pitch black, but you get the point. There's a diffusion abnormality that we can see in the mesenteric fat. And again, diffusion-weighted image, we then calculate the diffusion values for each individual pixel and display them in grayscale format. And here we can see that if you meticulously compare side by side, slice by slice, that this area of decreased or restricted diffusion corresponds to an area of viable tumor. Here's another example of postoperative assessment in a 78-year-old female with stage 2 ovarian. Post-op assessment. These are tough also. I mean, we see, that's a bowel loop, there's a little bit of fluid. What is this? The uterus is out, the ovaries are out. Is this post-op change? Is this a bowel loop? Is this a residual tumor? We did diffusion, nothing. 3 months later, all is well. So I think in that instance, there was some help to us in terms of being sure that there was no measurable disease. And finally, this is an 80-year-old female with a rising CA-125 after a radical hysterectomy. This is a CT scan. It was known that this was not part of the colon. So we're dealing with this mass here sitting in the central abdomen. This, if you scroll through multiple images, which I do not have, this is part of the colon. Above, we look at the diffusion-weighted image. There's this bright abnormality sitting in the middle of the pelvis. And lo and behold, the diffusion coefficient map demonstrates that the diffusion coefficient is restricted and therefore this is highly suspicious for recurrent neoplasm. So what can we learn from all of this? Don't drink the Kool-Aid. I think we have to be, open-minded about using CT and MRI in a complementary fashion. Both may be sensitive in the detection of peritoneal disease with limitations. Diffusion is helpful. It can be confusing. You have to be extremely careful interpreting these images. I showed you some numbers which quantitated diffusion in terms of the apparent diffusion coefficient. We do not report those numbers. The machine will generate those numbers, but at this point, in terms of clinical practice, really nobody knows how to use those diffusion-weighted numbers to generate a number that may help us to decide who are the patients that have tumor necrosis and who are the patients that still have residual disease that is viable. We do that subjectively based on interpretation of the grayscale images. And finally, it goes without saying that you just have to be careful. If you've got a busy day, put the studies aside, show it to your partner. If you're going to look at this in the clinic, use a split screen display to look at them so you can correlate the diffusion from the non-diffusion images to make sure that what you think is abnormal is matching up with the corresponding anatomy so that you minimize error. And that's it. Thank you very much.